That's my favorite movie. Hello, everyone. Good evening. I am so happy that you're here joining us, and it's just barely 8 o'clock, so we are going to give it a few minutes for everybody to get situated. Just before I hit go live, Dr. DeCaro and I were talking about our participation at the SAM conference is coming up at the end of January, and I usually have cardboard cutouts at my booth. And I don't know if you've ever seen the podiatrymeetings.com booth, but we usually have cardboard cutouts. The last at the National in Nashville, we had Dolly Parton. So this year, Sam is in Orlando, of course. I can't decide if I should have Shaquille O'Neal or Mickey Mouse or Hugh Jackman from The Greatest Showman because the conference is circus themed. So while we're all getting settled, take a minute to familiarize yourself with the chat and go ahead and pop your thoughts in that chat so I can see what you guys think I should have at my booth. And while you're doing that, I'll go over a few housekeeping items. We use Zoom Webinar for all of our webinar productions. So if you have questions throughout the webinar, go ahead and type them into the Q&A box. And that is something that only exists on webinars, so you may not be familiar with it, but it's a Q&A box. You can type your questions in there and we will get them answered at the very end. But I encourage you to type in your question when it comes to you so that you don't forget about it later. Um, this webinar is going to be recorded, of course, like always. So the recording will be available online within the next few days by the end of the week for sure. So if you have to log off or something like that, just know that you can find it on the website on our webinar archives page later this week. If you have any technical issues, you can always drop those in the chat and I will do my best to help you. Oh, chat is disabled. That sounds fun. Okay, thank you. I'm going to see if I can fix that. Everyone. Hi, everyone. All right. We'll see if that fixed our chat. But I do appreciate you trying to tell me that what cardboard cutout was your favorite. Okay. So we're gonna go ahead and get started here in just 1 second. It's only 8:02 and I feel like I've been talking for 5 minutes already. All right. If you don't know Dr. DeCaro and haven't seen him lecture someplace, you might be living under a rock. But just in case you're not familiar with him, he is a board certified podiatrist and surgeon. He owns DeCaro Total Foot and Ankle Center in Massachusetts. Is that right? Massachusetts or Connecticut?
Massachusetts.
Massachusetts. Okay. He's been in practice for over 20 years. He's board certified with the American Board of Multiple Specialties in Podiatry. He is recognized as Podiatry Management Magazine's top 150 most influential podiatrists in America. And he has tons of professional affiliations, including president of the American College of Foot and Ankle Pediatrics, and that's ACFAP. They have their annual conference in the fall every year at a national park. And it's all centered around pediatrics. And you get to go on an excursion in the national park. And this year in 2025, what national park are we at?
We are Rocky Mountain National Park,
Rocky Mountain National Park. So that'll be fun.
and this is our 10th annual.
Wow, that's
Yeah.
big time.
And so we have an extra special surprise for people going on the national park outing. It's going to be amazing.
Well,
And
that's exciting.
actually just finalized the agenda. And on our webinar in 2 weeks, how to grow a pediatric practice, I'm going to be launching the agenda. I'm gonna
Awesome.
unveil it there.
Well, that is exciting. Um, so we will learn more about all of that later on in the next few weeks. He's going to talk to us tonight about biomechanics for the 1 to 3 year old patient. He was just saying that there's not a lot of people that treat 1 to 3 year old patients. So maybe you guys are all here because you want to treat 1 to 3 year old patients. So, Dr. DeCaro, anything else I should cover before we get started?
No, I think we're good. I got it.
Awesome. Sweet. Well, I am going to mute myself and turn off my camera so I'm not a distraction. I'm still here hanging out listening, and you go ahead and get started.
And then we'll do some questions at the end. People can put their questions in the chat box and we can save them to the end like we normally do.
Yes, put your questions in the Q&A box. That would be best.
Okay, great. Awesome. Well, thanks, Anne. Thanks to Podiatry Meetings for having me back. Once again, I'm Louis DeCaro. I probably met most of you. Like Ann said, yeah, we'll be in Orlando in 2.5 weeks at the SAM seminar. I'll be doing an hour and a half on pediatrics on Thursday afternoon. So stop by and say hi if you're down there. I'm in private practice in Massachusetts, specialize in pediatrics, and actually renamed this presentation 0 to 3-year-olds. The reason why it's not 1 to 3-year-olds anymore is because I realized that I treat a lot of kids under one as well. In fact, I would say probably 50% of my patients today were under the age of 3, and a few of them were under the age of 1. This is just a kind of a snapshot of my website here, and I'll say this a few times. But you can go to my website, DeCaro Podiatry, and there's a ton of information on pediatrics. Also, reminder, my email address is drlewisjames@gmail.com. Send me any questions, pictures of kids, case studies, you name it. I'm always there to help and help you solve pediatric mysteries. All right, so we'll move forward here. I put this little thing together, this little slide today. I think this is our 7th webinar. We've done becoming a biomechanics expert. We've done the tween foot. We've done in-toeing, toe walking, growing orthotics in your practice, secrets of orthotics. Upcoming this year, we have sports medicine injuries, sports medicine prevention. We're going to do one on the myth of growing pains. We're going to do one on how Sever's disease and Osgood-Schlatter's are intimately connected biomechanically. We're going to do one on autism, sensory processing disorders. And in 2 weeks from tonight, mark your calendars, growing your pediatric practice, the growing your pediatric practice 101. So tonight we're going to talk about 0 to 3-year-olds and the biomechanics involved in them. And what you have to remember about all your patients, and you'll heard me say this 1,000 times, but everything is the biomechanics, and you don't outgrow it, you compensate it. And it's never, ever, ever too early to tackle the biomechanics of all of our patients. Most of the patients in the podiatry world are past the point of no return, meaning surgery becomes the only answer, or even pain becomes a permanent thing in their lives. My passion is trying to prevent all that, seeing kids as early as possible, identifying their foot structure, identifying a screening process that they can take with them throughout their whole life, and really kind of setting up an understanding of their feet and how they evolve throughout life. But everything is biomechanics. Genetics, this is a theme, this slide I put in every single presentation I do because our foot structure, everyone on this Zoom right now, everyone who registered, everyone who didn't register, all of you have a certain foot structure. That foot structure is an amalgam of your mother, your mother and father, your grandparents. The genetic tree is very tight when it comes to the foot world, and we can identify foot structure and its effect on the body at a very early age with the use of genetics. And it's quite interesting. I'm going to talk about that today. So when I'm seeing these 0 to 3-year-olds, I'm going to say this multiple times, and I'm going to say this in 2 weeks when I talk about growing your pediatric practice, but making sure that you bring the parents into the treatment room, making sure that the parents take off their shoes and socks, making sure that you have a good genetic history of foot structure, foot abnormalities, gait abnormalities, biomechanics, you name it. Because at the end of the day, who gave you those feet and who did you give those feet to is a very powerful statement. We're going to talk about this once again in depth in 2 weeks. about how to grow your pediatric practice. But in general, the treatment room is all the opportunity that you need, not only to grow your pediatric practice, but also to understand what you have in front of you. I probably saw, I can't, maybe 6 or 7 kids under the age of 3 today. Um, no, more actually. And both parents came in most of the time. One time, one mother came in, not a father. Everyone took their shoes and socks off. And I would say almost every single time, the foot structure of the parents in the room helped me treat the child better. Understanding the biomechanics of a child who's just pulling to stand and what they're going through and the challenges that they have are easily unlocked by understanding the parental history. You are what you eat, and our genetics are a powerful thing when it comes to our foot structure. Correction is a poor substitute for prevention. All the fixing we do later in life, all the surgery we all do every day, all that stuff is a poor substitute for the prevention that you can do in children, especially the 0 to 3-year-olds. A patient who has hip or knee pain or shin pain or knee pain, you often can tell that they might be exposed to that pain at a very early age in life. Ask your patients when they come in, does mom have knee pain? Does dad have knee pain? Grandma, grandpa? And you'll find that these things, they run in families. And you'll find that the foot structure of these little kids, their brothers and sisters, they're all very, very similar. And if we can prevent these things that we know inevitably going to happen, that's so much more powerful in my mind than correcting it. Doing nothing is a terrible treatment plan. It's very sad to me. I would say probably half of my patients today that came in had seen someone else first. And the plan was do nothing. The plan was let's watch it. Let's see if we're going to outgrow it. Let's see you back in 6 months. You're tripping and falling a lot now. Let's see if you're still doing that in 6 months. You're toe walking, you'll outgrow it. You're in toe walking, it's going to be fine. Come back in 6 months. We don't need to do anything about it. It's just not true. You have to do something about it. You have to figure out, or you have to learn how to figure out how to do what to do for every patient as early as possible. You don't outgrow this stuff, you compensate for it. One philosophy that I go by, and this is going to sort of going to start our lecture here, is that you have to remember when you're specializing in kids, especially treating young kids who may be nonverbal, they may be on the spectrum, they may have sensory processing disorders, they may have a condition where they're not able to communicate with you. Um, you always have to remember that a patient's diagnosis is based on their medical findings, not what medical condition they have. They have CP, they have Down syndrome, they have autism, they have sensory processing disorders, they have a certain central nervous system disorder, they have a certain muscle disorder. We can't pigeonhole them into thinking them as a disorder. We have to treat them exactly the same. We have to look at their foot structure the exact same way for every single patient, regardless of their medical diagnosis. We take into account their medical diagnosis, but we don't treat them as a medical diagnosis. Many of you have seen my talks before, either in person or on TV or on the internet or on my website or wherever you may go to find them. You know that in general, my principle is all sort of leans on our patented foot type methodology, that there are 24 functional foot types, and these 24 functional foot types produce certain orthopedic conditions throughout life. Once again, these 24 functional foot types really start to take shape, and you can really appreciate which of the 24 each person is somewhere around the age of 8 or 10. However, we've been able to identify kids as early as 2 or 3 on where they're going to be landing approximately on the foot typing chart. And we can get pretty darn accurate at it once again, using the genetics. So my whole basis is understanding, certainly by the age of 8 or 10, where they are on this chart. Once we understand where they are on this chart, we understand callus pattern, gait pattern, we understand orthopedic conditions, we understand things they're exposed to later in life biomechanically, the type of orthotic we make them, everything about them. But we also can take this and we can work backwards even younger than this. And that's what today's lecture is. So this is a very common picture that I've shown many times before, but I think it's a very powerful picture. And it's just really a reminder to make sure that mom and dad are taking off their shoes and socks. And in this instance, this child who's 1 year old is an absolute carbon copy of dad. And you start to notice that these patterns. So dad will qualify him as somewhere around a 19, 18, 19 foot type. We know that an 18, 19 foot type has a forefoot varus. We know that it creates a lateral arch. We know that it creates an abductory stance. And we see this in young children at a very early age. But what we have to realize is that the reason we can't put them in one of these categories is because their feet are not mature and they're not rigid enough. They haven't solidified enough and grown enough in order to grow into their adult form. But we see the pediatric flexible form of it, which often looks very, very similar. Looks are not deceiving when it comes to understanding children under the age of 3. Use their parents, use their grandparents, use their siblings to understand. You can have a family that comes in without mom and dad, and you can have, let's say, a 17-year-old brother, a 15-year-old sister, and then you can have a 1 or 2-year-old patient who comes in and they can all take off their shoes and socks. And you can know a lot about genetics from that. Maybe the 17-year-old had shin splints, maybe the 15-year-old had Sever's disease, and then maybe the 1-year-old that's seeing you has gross motor delay. So, what do you do with these patients that are 3 and younger? And I retitled it 0 to 3 because we see kids all the time that are pulling to stand and cruising and starting to walk before the age of 1. So you can really biomechanically start to have an effect on a foot and how the patient stands and how their body matures as early as really when they're pulling to stand. And so we'll put kids in orthotics if needed younger than 1 years old. Of course, we don't need to put a child in an orthotic if they're not even pulling to standing or they're not even trying to stand yet, especially if they're under the age of 1. But really, at the beginning, that's when you want to start. The earlier, the better. I wish we could screen every single 1 to 2-year-old in this country for possible biomechanical issues throughout life. And while you're not going to nail it every time, using genetics, taking a good medical history, you should really have a good idea of what the child is going to go through. We've talked about this before, but in a child really under the age of 7 or 8, it's the rear foot position and it's the calcaneal position that is going to control really the position of the foot. And it's going to really rule how the ankle sits on top of the foot, how the knee moves, how the hip moves, how the core strengthens, how the hip abductors work, on how the whole chain sort of fits. And there's a lot riding on the calcaneus. I mean, the calcaneus and the amount of eversion that calcaneus has and the amount of foot collapse that has is like pouring a foundation. And if that foundation at the beginning is not stable, the house is going to fall down. And it's not any different in kids who mature to adults. In fact, it's worse. A building is a static structure. But a child and a human body is something that moves around a lot, and that can be much, 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 much worse. For ranges 1 to 4, a child most likely will have flat feet or feet that look flat. That's normal. So not all flat feet are normal, but it's very normal for a child to have a flat foot at this age. We've talked about in the past how much eversion you should see in the heel, and around the age of 1, somewhere around 6 degrees of heel eversion or heel valgus is within a normal range. We've looked at pictures before in other talks that I've given where we show how to draw the lines and look at how much valgus. But in general, you can have a perfectly normal flat foot because a valgus heel will create a flat foot. That's the rule in general. Until a valgus heel comes out of valgus into a neutral or a varus position, your arch will follow the heel. So an everted heel or a valgus heel, which is very normal under the age of 4, 5, and 6, that will create a flat foot. As we get past the age of 4, 5, and 6, a valgus heel should anatomically turn more into a varus position. And then is what creates the arch. So you have to be very careful where a child one, they come in, they have flat feet, that could be very, very normal. So we have to be careful when we're looking at that, but not all flat feet are normal. So in the age ranges 1 to 4, we'll most likely have a flat-looking foot. But there are two treatable, really, with an orthotic issues at this age. Number one, they're pretty simple actually. The degree of valgus is there way more than 6 degrees of valgus. Is this heel valgus just completely significant where it's causing this extreme pronation and collapse? And or is there a milestone or gross motor impairment created from this foot? And that's a big one, right? That can be really anything, all encompassing. Do the parents have a concern? Is there tripping and falling? Is the child hurting themselves? Are they lazy? Do they lack endurance? Are they suffering from gross motor delay? Are they in early intervention and they can't get core strength, hip strength? They can't stand up straight. Is their posture off? There's so many factors that the foot can involve. So I created this scale under the age of 3 or 4, to ask yourself and your parents. I've named it the DeCaro rating scale. I pay myself my own royalties. And it's really kind of three sort of questions you have to ask yourself and parents when you're evaluating a child with a flexible flat foot when they just begin to walk. How flat is it? You can get as involved with that as you want. You can take x-rays. I don't, if it's just a purely flexible flat foot. You can try to measure the amount of calcaneal valgus. You can take your goniometer and get on the ground and try to measure the calcaneal valgus. That may be something that you do to start. But really, once you start seeing patients, you're going to realize what 6 degrees of valgus looks like, and you're going to be able to sort of judge that a lot better. I've been doing this 25 years, so I really sort of go all on visual now, and I have a really good idea what the valgus is without even measuring it. If I need to note something in the chart that's extremely significant, that's actually affecting something bigger, I'll measure it just to chart it. But that's something that you can learn pretty fast. Is there a family history and a parental involvement? This goes back to the whole genetics question. Um, if a child is in toe walking, they have flat feet, they have any of the things that I listed, usually there's something in the genetics where the one or both of the parents or siblings in, um, dealt with something very, very similar. So that's number two. And then number three is, does the foot impair the child at all? And we call this one parental intuition. Parents bring their children to doctors because they're concerned about something. I've brought my children to doctors and I'm concerned about them. And the problem is in the podiatric world, and I hate to say it, but often these parental concerns are ignored. I think I said today I had a plethora of them. Every day it's the same story, and I'll see these over and over again. They'll outgrow it. Let's look back in 6 months. It may be too early to treat. It's not too early to treat. If we have a goal, we get on it. There's no waiting. If a child is toe walking, the longer you wait, the more they're going to be prone to things like tightness, compensation, postural changes, changes in so much of their body habitus that you want to get on this stuff early. There's no reason to wait. There's no reason to be scared of with the proper education treating a child at a young age. Our goals basically are to stabilize these kids, stabilize their foundation. So, um, one question I get often, okay, well, we have these kids and we want to put them in something. What do we put them in? How do we know under the age of 3? Everything looks so darn collapsed. The ankle looks like it's collapsed. What do I put them in? Do I put them in an over-the-counter orthotic like my Little Steps orthotic? By the way, this presentation is sponsored by Nolaro 24. I'm a co-owner, and we make Little Steps orthotics. Little Steps orthotic is an orthotic that I helped create about 15 years ago now. We created it as an alternative to a custom orthotic, which is expensive. And there really wasn't and still isn't anything on the market that has the ability to control a flexible flat foot the way that it does. So do we put them in something like that? Do we have to make them a custom orthotic? Do we get them an arch support? Like we will throw some of our adult patients in, um, or do we put them in an SMO, which is a brace that goes above the ankle or even more? I don't have a picture of it here, but an AFO, and you've all seen pictures of AFOs. So how do we know this stuff under the age of 3? Um, I believe that most collapse and most conditions that we're going to see in kids who are struggling to walk under the age of 3 actually come from the foot causing most of the issues. However, in my practice, I'll see kids all the time that come in with these very large, bulky, heavy braces that go above their ankle, even below their knee. And these are for kids that have no sort of neuromuscular issues. It's just simply that their ankles are collapsing. But what I encourage all of you to do as you're getting more into treating these kids under the age of 3 is just simply putting an orthotic like my Little Steps orthotic under their foot, looking at the ankle, and seeing what amazingness can be done by just holding that heel out of a valgus. Um, and most of the time, it's not the ankle collapsing, it's the foot collapsing the ankle. We always have to be considerate of coverage. Unfortunately, in many states, AFOs and SMOs, so SMOs, once again, is the brace on the right there that goes just above the ankle, and AFOs are covered by insurance, but that certainly doesn't make it right to over-treat a patient. I find that many children are unnecessarily put into bracing. There are some that need it, of course, but they're unnecessarily put in bracing, and it really restricts the normal motion of the foot and ankle and body, and that can really cause harm down the road. Um, and then, but you have to decide that. And that's one of the reasons we came up with Little Steps was to create an affordable orthotic that, quite honestly, is pretty much as good as a custom orthotic, if not better than many. And we'll talk about the features of it in a minute, except for a few certain conditions, which we'll talk about. All right, let's go to the next slide. This is a very common picture here. And here's a kid that the valgus was greater than 6 degrees, and we put them in a Little Steps orthotic. The Little Steps orthotic has a deal peel cup, 30 millimeters of depth. If you're making a deep UCBL for a kid under the age of 3 or 4, you want 30 millimeters of depth in the orthotic. That is imperative in order to control the heel. If you put a child in a flat orthotic with a heel cup that is not deep enough, it will not hold the heel will collapse, and it will look like the child needs more support. You must have them stand in something that's going to control that heel in order to properly treat them. And we created it for this purpose, the Little Steps, as really a great treatment and evaluative tool for this. The patient has to have, and the orthotic has to have a lateral clip. That's what that arrow is pointing to on the lateral column to really stop that foot from abducting. Because if you've seen many of these pediatric flexible flat foot, that flat foot will abduct out and collapse. You need that wall on the lateral column to hold the foot. And then you really need a nice aggressive skive and arch support to hold that foot in a good position. So little steps. Since they're sponsoring this, we're going to talk about them, and I use these in my office all the time because they're much more cost effective than a custom orthotic. Sometimes they're covered by insurance, sometimes not. But the difference between, for example, a $100 device and a $600 device, like a custom, can be huge for parents. 30 millimeters depth heel cup, medial lateral flanges, like you saw, medial rear foot posting and skive, and they really fit most kids all the way up until the age of 12. They help kids with coordination, with balance, with pain. We rarely get kids under the age of 4 with pain, but sometimes growing pains, we put that in quotes, it's a myth. If any of you have ever heard me talk, is something that you can treat in strength and foot alignment. So we have fitting guides that we give out here. I think this is really, really important for everyone to see. We usually like to go up to the metatarsal neck in order to correctly fit a little steps. And these are two good illustrative charts that when we set up doctors, we provide for them in order to help fit well. Here's that flexible flat foot. There, you see this little girl. Looks flat standing, but look at her in her dad's lap. Look at that nice arch. So these are common sites. This mother here, you can see her lateral arch on that right foot. That's a sign of forefoot varus deformity. We'll talk about that a little bit more in a second. And that you can see her knee is internally rotated, and you actually see the exact same foot of her daughter who is 1 year old. However, the daughter's foot is presenting as an abducted foot structure in this picture. And that is exactly the same foot. I call it the triple threat, the false, flexible, flat foot. False meaning this foot looks flat, but it's not going to be flat. You can see the arch there. And you can use the genetics, and it's flexible and it's a flat foot. It's not, excuse me, not a true flat foot, but it causes a lot of destruction to the rest of the body. Treat a lot of patients with Down syndrome. Down syndrome in the literature, really the accepted time of walking is somewhere between 24 and 36 months of independent gait. And I completely disagree with that. Every day we see patients with Down syndrome that we put into a deep UCBL, sometimes even little steps, and they're walking much earlier than this. These children with Down syndrome, specifically in this case, they have that ligamentous laxity and their foot is just splaying out and just a terrible foundation. And regardless of the diagnosis of Down syndrome or not, if you have ligamentous laxity and you have that much flexibility, you're not going to be able to stand until at least 24 or 36 months. And so I say, come on, really? We got to get to these kids earlier. Children with Down syndrome almost always have flat feet, so isn't that normal? No, it is not normal. Once again, we treat these children based on the same parameters that we would treat a child who doesn't have Down syndrome. Physical therapy, most of my referrals under the age of 3 are from early intervention physical therapists. We'll talk about this more in 2 weeks, but this is a subset of physical therapy and occupational therapy and speech therapy who specifically work with children under the age of 3. We'll talk about how you get referrals from them, where they work, what they do. But one of the things that I do working with them and I've tried to train them is for them, specifically the physical therapists who are trying to get kids stronger, to put them in a really good orthotic first, especially when the foot is not helping them out with their strength, their gross motor milestone, and then do the physical therapy tips. So this isn't a slide necessarily on me giving you tips of the type of physical therapy for them to do, but me more saying, let's get them the foundation first and then the physical therapy, as opposed to the physical therapy with a foundation that's just really unraveling and collapsing all the work that you're trying to do. Get children so often that have weak core, they have weak hips, they're difficult time standing, their posture is off, they have a weak core, and I see them go through physical therapy and they just don't make any headway because they're trying to basically fix up their second floor and the foundation is just collapsing and undoing that. So getting them an insert before is really, really important. And I think that actually has taken the average age of my patient way down for when it used to be 3. Now it's more in sort of the 1. We're getting them before the physical therapy starts. We're going to do a whole talk later in the year on autism spectrum disorders. But a reminder, there's many kids on the spectrum these days, and we treat tons of them. They're often associated with things like sensory processing disorders, excuse me, and other comorbidities. Same protocols. Be aware what specialists they see. Children who are diagnosed with autism, especially in some states, are able to get a lot of different services. And these services, after being screened, can tell you a lot about what the child's dealing with. Do they see an eye specialist? Do they see an OT? Do they have a sensory concern? Is their vision not strong? Is that affecting their gait? Just really paying attention to who is treating these kids. So when a kid comes in and they're really young, I want to know all about their family and I want to know all about the treatment that they've undergone for their full body, not necessarily just their foot. Looking for nonverbal cues and making sure that we still focus on the patient, talking to the patient, um, not to necessarily the parent. Sensory processing disorders. This is a condition with multisensory input is just not adequately processed. We have a lot going on. We're trying to smell, we're trying to taste, we're trying to see, we're trying to walk, we're trying to touch, we're trying to balance. We need an awareness of where we are in space. There's a lot going on. And sensory processing disorders that many children have. You can be on the sensory seeking part of the spectrum. You can be on the sensory avoiding part of the spectrum. You can have a sensory processing disorder that can cause toe walking, that can cause all different changes in gait. You have to be aware of these and you have to be able to recognize how sensory processing plays a role. One other thing, too, and I said that little steps most of the time is perfectly great for a deep UCBL, and you don't need a custom. But sometimes we'll get kids with sensory processing disorder where we want to put a soft top cover on an orthotic, and we cover the little steps with a soft top cover. Or if that's or if we need to go to a custom orthotic, sometimes we have to be cognizant of the type of material that we use in an orthotic. You can, without knowing, you can try to put a child in an orthotic and they don't behave well in it. They don't want to wear it. They take their shoes and socks off. And unless you ask the questions of what's their sensory processing or sensory processing profile, you may not be aware that they don't like hard surfaces. They don't like cold surfaces. They don't like standing on plastic. Or they don't like soft surfaces. They respond better to a hard surface. So you really need to get their profile under control. Foundation is very, very important for these kids. We're going to briefly talk on toe walking. I did a whole segment. You can go to podiatrymeetings.com and go to the archived meetings on toe walking and in towing. I saw 2 kids today who one was 2 and one was 1.5. And they had been to several doctors already. And they were basically diagnosed as toe walkers, idiopathic toe walkers. No one could figure out why they were toe walkers, which I refuse to accept. And that, unfortunately, is the kind of common theme. With toe walking, it's, well, they're toe walking, they'll probably outgrow it. We don't know why it's happening. It's normal. These are things that you hear all the time. But you talk to a parent who's dealing with a child who's toe walking, most of the time it isn't normal. Most of the time the balance is off. The parent doesn't like the way that it looks because they deem it not normal. And so you really need to come up with a diagnosis for these. And we go in depth in that webinar and talk about sort of dispelling all the idiopathic diagnosis. Tightness, of course, is very, very common. Um, with toe walking, but often children are misdiagnosed as being tight. Either it's tone and not true tightness, or whoever measured them doesn't know how to measure equinus. So make sure that you brush up on your equinus measuring ability. Neuromuscular, central nervous system, of course. Vision plays a huge role. Always make sure that you do a screening of vision. Sensory processing disorders is an absolute huge one. And then compensation, like we talked about, for that early E foot type, and that's looking at the parents. And I'm not going to go too in depth in this one because we have just a lot of to kind of skim over today. But this foot type, you've heard me talk about it many times. We're probably going to do a webinar just on this one. If you go to DeCaro Podiatry, there is articles that I've written on it. There's videos that I've done on it. But this foot structure is a toe walker and an in-toer at a very young age, and you can even see it with genetics under the age of 3. So basically, I'm not going to go in depth in this because I already have, but brush up on this E, brush up on my videos of how the E causes in-toeing and toe walking, and even put a PDF of my article, Evolution of the E Foot Type, which talks about how the E causes toe walking and in-toeing. And to make a long story short, if you have or going to be an E foot type later on in life, and you have that premature rigid forefoot varus, it's not rigid yet, but that premature forefoot varus, you're toe walking and in toeing for balance. And so that's just a little bit of a teaser. Here is an E foot type. This is a classic 17 standing in front of us, a mom, and then a child who toe walks with the exact same foot type. So we definitely want to get to them at a very, very young age. Remember, toe walkers, I wish I could take a poll, but we can't really. But anyone who treats kids on this Zoom knows that much of the time, and I hope this isn't true. I hope everyone says I'm a liar about their practice. But unfortunately, many of the kids that most of you get who are toe walkers, they're tight. Why? Because they've been toe walking for a long time. It's amazing to me where a child will come in at 10 and they saw another doctor who said, "Oh, they're toe walking because they're tight." Well, it usually doesn't start with tightness. I would say a very small percentage of these 1 and 2 year olds that I'm seeing are not tight. I would say that tightness, even though there's this myth that toe walkers, most of them are tight, most of them do not start out tight. But if you toe walk for years and years, if you wear a high heel for years and years, you're gonna get tight. Aquinas breeds Aquinas breeds Aquinas breeds Aquinas, and so on. So remember, when you're treating these kids, one of the reasons to get them under the age of 3 is you can solve the chicken or the egg question. You can say, I get it. I know what the chicken or the egg is. But at 8, if they're tight, you don't always know what the chicken or the egg is because they've been walking on their toes. So saying that a child is a toe walker at the age of 8 or 10 is their toe walking is because they're tight. I'm sorry, it's just not a good argument because it's probably not the reason it started. So you got to get a better history of when they were really young. You got to get a better genetic history of their family, and you got to stretch them like crazy. I'll show you later in this presentation that I'm doing a master's class. We do a master's class every year. It's a 2-day immersive class where we teach biomechanics of pediatric and adult. And this year, we're sharing the class with my good buddy Patrick DeHere, inventor of the Aquinas brace. Um, and you get them in these braces really, really early and stretch them if they're tight, or if they're 8 or 10 and you're trying to figure out what that toe walking is coming from, you have to stretch them out first, and then you can start to unlock things. When I get a child who's really young, whether it's sensory, whatever the reason is, you put them in little steps and you one size up them. So I showed you that slide of where you kind of the fitting guide of where you sort of fit the distal end of the orthotic to the met next, where you go past the met next to the sulcus, and that really helps deter the child from toe walking. It's an amazing proprioceptive aid. It for sensory kids, it's amazing. Over 6 to 12 months, you put a child with sensory processing induced toe walking in a little step that one size up, and they really, really do amazing. Here's a slide on the right. Is sort of the normal way you would have a UCBL fit a child or a little steps, and on the left is how far we go, if not further. Actually, could have a better slide than this, if not further, to really stop them or discourage them from going up on their toes. And when it's sensory processing, which I would say is most of the children who are toe walking that and premature E foot type, this can be very, very helpful. So this is helpful with the premature E's and the sensory processing kids going a little bit long. In towing, once again, we did a whole half hour on that. But in towing also may be a compensation for flat feet. I've told this story before, but I've had a 10-year-old who stands abducted, and I've had a 4-year-old who walks in tow or adducted, and they have the exact same foot type. But basically, and I'll really super make it simplified, if you have an ultra flexible flat foot in a really young child, and everything is loosey-goosey, when they land and their heel everts into valgus, sometimes that forefoot, if you got that premature forefoot varus in there, it'll just collapse immediately and not look like, it'll actually be in towing, but it won't have anything to do with the femoral torsion. It won't have anything to do with tibial torsion. It won't have anything with metaductus. It won't have anything to do except that foot is so ultra flexible with a premature rigid forefoot varus or that E foot type, which we've talked about. And once again, if I'm losing a bunch of you, go to my lectures. Go to DeCaroPodiatry.com. I got a ton of lectures, ton of articles. Go to podiatrymeetings.com. Come to one of the lectures that I do. Let's see, we got the SAM hour and a half. We got our master's class in May. We do these, we're doing twice a month. We're doing pediatric education. Just hop on the wagon. Uh, we little steps. We also created a gate plate too. Gate plates are awesome for in towing. We use these for all sorts of torsional deformities, tibial torsion, femoral anteversion. We'll use them for almost all in towing, where we want to actually use that lateral distal end as a sort of a fulcrum to abduct, externally rotate the foot. That's how you properly fit a gate plate. So little steps also come in gate plates pre-made for you. Oh, here's my website, DeCaro Podiatry. We got, like I said, tons of articles on there, publications. How to assess a child with a flat foot, evolution of the E foot type, shoe recommendations, shoe sizers. I've done a ton of appearances on NBC, which actually is, I think, is really good for practitioners to watch and just kind of understand simple things that you'll see in kids, especially under the age of 3. Um, if you see here at the top, it says, "What's my foot type?" Once again, I send all my patients who are over the age of 10 to note their foot type. I think that's important. Every child that sees me, this is a kid who's under 3 with a flexible flat foot, who had really poor balance, was falling and tripping and hurting themselves. The gross motor milestone delay. This was a genetic case. We put him in little steps, gave the parents tons of articles, educated them. Great stuff. Changed this child really forever. And it's interesting because we get this sort of question from parents all the time. If we put a child in an orthotic at a young age, do we make them dependent on it? And I say unequivocally no. What we do is we give them something to improve their mechanics, improve their foot structure. You don't say that when you put a child who's 2 in a pair of eyeglasses that you're destroying their eyes going forward. You're making their eyes work better. And some eyes weren't made perfect. Some feet are not made perfect and they need help from a young age. We got to get over this whole thing of like how the foot is somewhat different, somehow different, and how it's going to miraculously change or get stronger or change what it's destined to do. It's not. And if you put them in an orthotic, while you may take them out of an orthotic for a period of time because you don't have a justification, if you understand what a certain foot structure looks like at a young age under 3, and you explain to the parents what that foot structure means and why you're putting them in orthotic and what to look for in the future, you'll get tons of patients who will come back 7, 10 years later and say, I remember you told me that my child may be predisposed to shin splints. I remember you told me that if they have heel pain or they have Osgood-Schlatter's or they have any sort of issue, it could be their foot type. So you're really creating this sort of lifelong education. And once again, I'll say this again, I don't mean to be redundant, but I feel like every child should be screened at an early age, just so that the parents understand what to look out for. My child is screaming. They're 5 and 6 years old. And I took him to the doctor, and the doctor says it's growing pains. Oh, yeah, I remember when I took my child, same child, when they were 1, and Dr. DeCaro put him in an orthotic to help their gross motor milestones. He said they may have these things called growing pains, and they bring them back to me, and we put them back in an orthotic. I mean, it's rewarding stuff because you know you're making a lifelong distance. Once again, if you're not familiar with this, learn it. Come to our master's class. We'll teach it. Um, this is that I just love sewing the slide. It's just everything. We have the fitting guides for both the regular little steps and the gate plates. We have sizing guides for you. Um, and you got to join ACFAP. I mean, acfap.org. Go in there, join. Ann and I are going to do 6 different webinars, I think, this year, just talking about pediatrics specifically, sponsored by ACFAP. This is a meeting that we get together and we just go into a room for 2 days and just learn everything and anything on pediatric, from conservative to surgical to MIS to sports medicine to tarsal coalitions to early treatment, sports medicine, physical therapy, vision, orthopedics, everything and anything, multi-specialty. We spend the day before the meeting in a national park all together, getting to know each other, sharing cases. Join ACFAP, check out the website, come to our 10th annual meeting, which is going to be special, acfap.org. Yeah. Scan this code. I know, Anne, I see like in the corner of my eye, we're getting some requests of like how people can get little steps, how they can get more info on ACFAP, how they can get more information on this master's class that we do. We've had that request before, and I know Anne will probably talk about what she's going to do to get that out. But this master's class, see, my buddy Pat and I and Roberta and Joey to here. We're going to do 2 days. We're going to lock you in a room and just do everything and anything biomechanics. I'll cover most of the pediatric stuff. Um, they grow up fast. I mean, your little girl who will wear the dress turns into the girl who won't wear the dress anymore. And you got to get them early. That's my email address, drlewisjames@aol.com. It's drlewisjames@gmail.com too. If you want more information on Little Steps or Little Steps gate plates or a master's class or ACFAP or any of my articles or permission or videos, you can email me. You can email my company, Nolero24. Come in my office and shadow me, send me cases, whatever you want to do. So, and I tried to keep it shorter than that, but I get a little bit overexcited. This, it's sometimes I'm not going to call it criticism, but feedback. It's like, I'd like you to go more in depth about X, Y, or Z, but that's why we're doing like 12 of these this year, right? Because
Yeah,
you know, we got to go in depth in some of these topics. We kind of brushed over them today a little bit.
exactly. I think in 2024, we kind of touched on a lot of different things. And then in 2025, you get to really hammer all these messages home. So I think it's going to be good. All right, before we get started on the questions, I want to make sure that I give the right links to people. I did drop Dr. DeCaro's email address in the chat so you can copy it straight from there. Should I share just the regular Nolaro Little Steps webpage here? Is that the best thing for?
Yeah, I think that's best
Okay,
for practitioners.
sure. Okay. All right.
And
Yeah.
then,
So
and we have this, you're going to be doing some emails about the master's class that's coming up in May, right?
Yep, absolutely. So we've got lots of different things coming out there. I just wrote myself another note to send out an email about your lectures at SAM. And then I think we're offering some kind of promotion for ACFAP at your next webinar.
We are, yes.
But I have to
And
look back at my
so
notes. So we'll put that
I
in.
haven't decided when I'm going to release the details of that,
Yeah.
but definitely it's gonna be a juicy one. So I know the Laro though for this one, I don't want to get ahead of myself, is going to be emailing all the attendees here a really good deal on either getting started or restocking their little steps. So look for that email in the coming days.
Awesome. Cool. All right, so let's get into some of these questions. Uh, if you put a non-pathologic by mistake in 1 to 3 year old patient in an orthotic, will that cause more issues later?
Yeah, it's interesting. By mistake, that's a really interesting sort of statement. I won't put a child in an orthotic unless I have justification of it. I'm sort of known as the person that wants to get them early, get them in an orthotic, and let's get on this. But I had a patient today that came in at 2, and I couldn't wrap my head around putting this child. I couldn't come up with a reason to put him in him. And so I didn't. And so I think you have to just you have to know the reason you're doing it. And if you know that there's a reason, you're not going to make a mistake. If the child is tripping and falling a lot because they have bad feet, you're putting them in something that's going to stabilize them. So I don't think really there's mistakes to be made if you're actually coming up with a justification. And one thing that I like to do in my office is I explain to the parent exactly why I'm doing what I'm doing, or exactly what I'm not doing and why. And if you can't ignore the parent, you can't ignore their concern. They're with the child. That child is tripping and falling all the time. You have to really dial into them. So I don't think you're going to cause more issues later. That's not something that's really come up in my practice. Um, I'll just go to the next question if that's okay with you.
Go right ahead.
I don't use the lateral malleolar index. I'll just really measure the valgus based on the amount of eversion from the posterior view. That's just what I do. Um, Hi, Mary, out in California. Nice to see you and your question. We'll see you at ACFAP this year, I'm sure, maybe in the Western. Great question. This is a state-dependent question. I think you need to check and see if Little Steps meets the guidelines for L3060. In many states, L3060 is the appropriate code for Little Steps orthotics, and you can bill that. I know in many states, Medicaid covers L3060 if that's appropriate. So yeah, definitely look into that in your state, what's covered, what isn't, and what the guidelines say, and if the little steps meet the criteria. I mean, the little steps are such an amazing orthotic that do really quite as much, if not more, than most custom orthotics. And that's sort of where the 3060 comes in, the non-custom versus the 3000, which is more the custom based on the mold. How does pronounced genuvalgum or varum in a 1 to 3 year old affect the fitting of the orthoses? That's a really, really good question. It doesn't affect the fitting per se, but I want to make sure that I do a good workup of where the knee positioning is and where that's coming from. Often it can become coming from weakness in the hip abductors. It can be rotational deformities, even in the femur. Sometimes and often it comes from the foot and ankle. So we're always looking at the knees also and what effect they have on the feet, what effect the hips have on the knees and have on the feet when we're fitting. But the actual fitting of the orthoses, not really a direct effect. What is best for a 3.3-year-old male? Oh, well, we were just doing 0 to 3 here, right? No, I'm kidding. That's fine. A 3.3-year-old male, occasional toe walker with flexible flat foot, normal 11 months started walking, speech delay, runs and jump. Well, so I don't know why they're occasionally toe walking. So we got to get to the bottom of this. Is it congenital based on that E foot type and that premature forefoot varus? And is it going to get worse? Is it improving? Is there a sensory profile? Um, how flexible is the flat foot? What's the E version? What's the valgus? What are the parents' goals? What are we looking for? What are the parents concerned? Why did they bring you in the first place? Is it more than just they're occasionally toe walking? Does it change with surface? Does it change in shoes? Can the child control it? That's a big factor. It's a loaded question. Wendy, shoot me an email and I'll be glad to look at some videos and pictures and talk about the case with you. I do it all the time. Oh, Teresa, how's it going? I'm excited to be lecturing for the PFA again this year. Thanks for the email. You have a question. What are your recommendations for footwear? How early for children's shoes? So, uh, this is going to floor some people, but if a child doesn't need an orthotic, the less shoe, the better. But if a child needs assistance, you need a good shoe. And that's really any age. So if a child can't stand up and can't perform and they need an orthotic, they need a good shoe. But if a child is normal, and I put that in quotes because what does normal mean? But they're meeting all their gross motor milestones, there's no goals. Let's get them out in barefoot. I mean, goes without saying we want them to be careful, right? And not go barefoot everywhere and step on things that are hazard, but as barefoot as possible. I'm a big barefoot guy for people that don't need assistance. Yeah, I'm flying through these because it's already 9:01, so I hope that's okay, Anne.
Yep, you're good. Keep
I hope I'm
going.
not losing too many people. Can Little Steps gate plates be sent back to get a soft cover? We soft cover all the time because specifically child needs something softer for sensory profile, or the parent just wants something as a top cover. We ship them actually from a custom orthotic lab. So Marianne, you can custom order a gate plate with a soft cover. Yeah, if you have some stock, you can send them in and we can soft top cover them whatever you want. A little one who refused to wear shoes with gate plates after first fitting. When she did okay, I put thin on top of it today and she tolerated it. Great, awesome. Yeah, we can definitely put that on. Um, so Young, how are you? It's great to see so many familiar, wonderful names. We'll see you at ACFAB. What is the mechanism behind having idiopathic toe walking patients wear one side larger insole? Yeah, so if they're toe walking because of a sensory processing disorder, if it's too long as they go up on their toes, they're actually going to be discouraged and they'll fall back to their heel, and that will train that sensory piece to be for the heel strike to be more common as opposed to going up on their toes more common. So if the brain is thinking, I have to go up on my toes, and that's the sensory profile, if you make the orthotic a little long, and they try to go up on their toes, it's not gonna feel good. And so they're gonna rock back to their heel, and that's going to create sort of a new sensory profile uh, for them. Hey Rob, how's it going? Long time no see. Do you prefer to put the patient right into an SMO or do you use an orthotic first with PT? SMO versus orthotic is purely where the deformity is coming from. Most of the time, it's an orthotic. Most of the time, the SMO is overkill. Sometimes it's not. An SMO, if the ankle truly is collapsing or the child cannot hold themselves up with muscle strength, you need an SMO. Sometimes you need straps with it. But whichever one is more important, SMO or orthotic, you put them in that first and then PT. Great question. If you suspect SPD, do you refer the patient out for confirmation? I make the diagnosis myself all the time. Yeah, 100%. Many times these kids have been diagnosed, and even if they don't, their parents already know that they have some sort of sensory processing disorder, and we'll consult them to OT, or many of them are actually consulted from OT. At what age do you decide to put a child in gait plates or orthotics if they are in towing? As soon as possible. If they're in towing and you figure out why they're in towing, Dr. Hames, I would refer to my other lecture that I did for podiatry meetings as early as possible. Once you figure out why they're in towing, if a gay plate is appropriate, the earlier the better. So, whew,
We
I
have, before you get excited about being done, we have two questions that came in through the chat. So let me read them.
oh, okay.
Thank you for the wonderful lecture today. May I ask, what is the mechanism behind having idiopathic toe walking patients? Oh, we already answered that question. Never mind. Here's the other one. If we're hospital based and can't carry little steps, what's the best way to determine size and get them the orthotic?
Oh yeah, well we do this all the time because there's so many large children's hospitals and PT, DPM facilities, MD facilities that order from us and can't, directly give it to their patients. So we have programs for this. So just email info@nolaro24.com or email me and I'll forward it to the right people at my company and we will set up a program where patients are able to access the product and you don't have to go through all the wonderful hospital hoops that sometimes you can't even jump through.
Yeah. Um, well, that was a lot. And you, like you said, sped through it. So it was a lot of information. I will get the recording up on the website before the end of the week for sure. So if you want to rewatch it, you can. Also, if you do anything with AI, you can watch it on YouTube and then have YouTube AI summarize it for you and give you
Oh,
the
wow.
talking points. Yes. So I am like this AI
I love it.
obsessed
You got to
person
teach me
now.
that at Sam.
Yes, for sure. So if you don't have time to watch the whole video, you can catch the highlights if you have AI summarize it for you. I really enjoyed this because, as you know, I have a little baby at home now, and we are just starting to enter this developmental phase. So thank you very much for telling us all the things we need to look out for.
Absolutely. You're welcome. And thanks everyone for showing up and having an interest in pediatrics. And the more pediatric podiatrists and specialists out there, the better for the general population. We'll see you in 2 weeks.
Yep, we'll see you in 2 weeks and at Sam, if not then. Yeah.
All right.
All
Bye-bye.
right. Bye.